Peripheral nerve injuries. Peripheral nerve carry information to the muscles to initiate movements as well as transporting sensory information. Nerve injury may present with sensory deficits, loss of motor function, or a combination of both. Classification of peripheral nerve injuries. Type 1 corresponds to neuropraxia characterized by local myelin damage secondary to compression. Type 2 and 3 corresponds to axonotmesis characterized by loss of continuity of axons, endoneurium, perineurium, and epineurium intact. Type 4 corresponds to sensory and motor deficits distal to the site of lesion. Type 5 refers to neurometastasis characterized by complete physiologic disruption of entire nerve trunk.
Motor nerves damage can be caused by injury from an accident. A fall or spots can stretch, compress, crush, or cut nerves. These nerves regulate all the muscles under your conscious control, such as walking, talking, and holding objects. Damage to these nerves is typically associated with muscle weakness, painful cramps, and uncontrollable muscle twitching. Sensory nerves damage can be caused by medical conditions such as diabetes, Guillain-Barré syndrome, and carpal tunnel syndrome. Because these nerves relay information about touch, temperature, and pain, you may experience a variety of symptoms. These include numbness or tingling in your hands or feet. You may have trouble sensing pain or changes in temperature, walking, keeping your balance with your eyes closed, or fastening buttons. Autonomic nerves can be caused by autoimmune diseases including lupus, rheumatoid arthritis, and Sjogren's syndrome. This group of nerves regulates activities that are not controlled consciously, such as breathing, heart and thyroid function, and digesting food. Symptoms may include excessive sweating, changes in blood pressure, the inability to tolerate heat, and gastrointestinal symptoms.
The model that we use is person-environment-occupation model that emphasizes on the interaction between the person, the environment, and the occupation. The frame of references that are derived from the PEO model that we used are the biomechanical FOR and rehabilitative FOR. The biomechanical approach is designed to restore client-level factors of structural stability, tissue integrity, range of motion, strength, and endurance. The interventions that we implemented are splinting, passive mobilization, retrograde massage, desensitization, sensory re-education. The aim of rehabilitative approach is to maximize performance in occupations through adaptation of environment or activity. The intervention implemented using this approach is the application of functional aids. The goals of these interventions are to reduce hypersensitivity, normalize the sensation, prevent further deformities and contracture. Next is to improve range of motion for functional act, promote greater competence in ADL, and facilitate functional use of the affected limb. The first intervention is sensitivity training, the desensitization. It uses repetitive stimulation of different sensory modalities that are slightly unpleasant but tolerable. The duration should be approximately 5 to 10 minutes, 3 or 4 times a day. Further grading, stimuli are upgraded when the client's tolerance increases. As a precaution, in early stage, gentle stroking needs to be applied to avoid from evoking greater pain sensation. The rationale is desensitization able to reduce pain by increasing the threshold level when being stimulated.
Rate the pain that you would feel with this in comparison to the pain that you would feel with this.
I can feel the cotton a little bit more.
Okay. Does this cause pain
most
for
of the
you?
pain is in the palm of my hand.
Okay, so fingers are pretty good. So if I do the same thing here, in that very center aspect of the hand versus
the cotton is definitely more painful.
uncomfortable.
Yeah,
More uncomfortable.
So what you're looking for with desensitization is initially it's going to increase your pain. But when you're doing desensitization, you don't want the pain to increase. I don't want to send you off the pain scale. This shouldn't take you from your baseline pain to a 10. The stress loading, scrubbing, carrying may do that, but with desensitization, I'm looking to keep you at a level that may be 1 or 2 levels.
Next is sensory re-education. It is used for clients with diminished of sensory function, involves training in localization and graded discrimination. It can be done in 2 to 4 times a day in 5 to 10 minutes. Stimulation of object is graded starting from dull or rough to the lighter or smoother. As a precaution, this technique can be used only if the client have intact protective sensation. If the client has lost protective sensation, use compensatory techniques for protective sensory re-education.
The task without vision and to give a response. Attention is critical for learning and heightens the brain's response to the sensation that is focused on. Feedback is also given on the best hand movements to explore a particular sensation. Their impaired sensation internally by reference to a more normal sensation experienced through the other hand and through vision. The person is also prompted to imagine what the sensation is supposed to feel like immediately after feeling it with their unaffected.
Moving on to passive mobilization technique. It is done when the client is unable to move independently in early stage. The frequency is 2 or 3 times a day in 10 to 15 minutes. If there's improvement, strengthening exercise and graded activity-based intervention should be encouraged. In performing PROM, client is asked to relax and make sure to report if they feel any pain. When the client has started to achieve active movement, exercise can be started with the aim to strengthen the targeted muscles. Splitting.
And over your head. And just let me know if I'm causing any pain.
Sure.
Okay? So we're going to go up. Does that feel okay? Any pain?
It's fine.
Okay. Here's one more. Any pain?
No?
And one more. Any pain?
No?
All right. So now I'm going to take your arm and go out. We're going to do abduction and adduction. So I'm just going to move a little bit. Switch my arms around. Okay.
In peripheral nerve injuries can be classified into static and dynamic. Static spleen has no moving parts. Dynamic allows mobilization of the spleen in flexion, extension, or rotation. Spleen should be worn the whole day except during personal hygiene activities. Usually worn in a duration of 1 week until 6 months, but it depends on the severity. The client needs periodic monitoring with the in-charge therapist as the regeneration of axonal nerve vary from 1 to 3 mm per day. As a precaution, sensory and motor should be monitored. Watch for deformities, educate patients on spleen care, and design should be simple and functional. Spleens are for the protection, prevention, or minimization of contracture formation and facilitation and enhancement of daily function.
Critical to ensure a 90-degree angle of pull. This perpendicular force will prevent shearing stress and unwanted traction of the joint. It is important to remember that as mobility improves, the therapist must reevaluate and make changes to the outrigger to maintain the 90-degree angle of pull. There are also several types of commercially available outrigger kits. These are usually applied by drilling or punching holes in the splint base and attaching the outrigger with specially designed thumb screws. Make any changes necessary to ensure the splint is fitting properly. It is also important to educate the patient on proper application and care of the splint to ensure compliance.
Functional aids, as in assistive devices, shall only be provided when the task demand exceed the patient's capabilities. For the duration, assistive technology is expected to be used in a long period of time because it does not provide changes to native ability of the user. The grading is done as the user's ability improved. Only then assistive technology shall be replaced. Therapist has the tendency to look at the client's ability of in using the assistive technology instead of focusing on the targeted task. This might cause inaccurate intervention and should be avoided. The rationale is that assistive technology is used to close the gap between the skills of an individual and the demand of the task based on human interface assessment.